on, guys? Can you see us? You can hear us okay?
Yeah,
So
we can hear you
welcome
guys.
live. I apologize. Hello?
Yeah, we can hear you.
Okay, yeah. So I apologize. I missed my talks, but here I am. I promise I'm not on a beach somewhere. So we're here in room 2. We're going to be doing the live SVC thrombectomy case with Dr. Fishman, Dr. Carlone. He's going to introduce the case in just a second. We have a great team here. We have Dr. Robert St. Jules, who's going to be running the TEE for us, and we're going to be doing TEE guidance and hopefully get some of this clot out. Tim?
All right, thank you, Dr. Sheila. Okay, next slide, please. So on the table, we have a 50-year-old gentleman, end-stage renal disease dialysis patient who initially presented with fevers and pain and discharge around his tunnel dialysis catheter site. So the catheter was removed. We got some purulence out of the tract. He had blood cultures and cultures from that removal that were positive for MRSA, and those did not clear initially, and so that prompted further workup with echo, as you'll see in a moment. Medical history and surgical history are, as you see there, kind of expected things for an end-stage renal disease patient. Next slide, please. Those are his vitals on presentation. His Tmax was kind of low-grade fevers. He's been well since the catheter was removed. On exam at the site of the catheter removal, currently he has no pain, no erythema, no discharge. On presentation, his white count was 20. It has since normalized on antibiotics, and his blood cultures were positive for MRSA, and they were positive for 4 days after the catheter was removed while on antibiotics on serial daily blood cultures. So a TTE and then subsequently a TEE were obtained, which we'll show in a second, showing a mobile friable mass and kind of the SVC extending into the right atrium. Next slide, please. So this is the TEE. It should play both sides in a second. Yep. So just to orient you on the left-hand video, we're looking at the right atrium. On the right side of the screen, you have the SVC, and you can see that mobile mass sort of extending into the right atrium. On the right-hand side of the screen, we see that as well as a transverse view kind of through the cross-section of the SVC, and you can see this is this long, thin mobile mass, fibrin sheath there. Okay, next slide. So we were consulted at this time for treatment planning purposes. We got a CT. It's running fairly quickly, but I'll show some stills that show that that thrombus fibrin sheath. And then worth noting, there's nothing in the there's nothing below the atrium. Next slide, please. We go back one slide. Do we lose our images or still shots? There we go. These are just some still shots from that CT. We can see the long filling defect fibrin sheath. CT of the neck was obtained as well, and you can see that the thrombus extends into the subclavian and a little bit up into the IJ, but everything is patent. So next slide. Next slide, please. Oh, there you go. So in summary, we have a 53-year-old gentleman initially admitted with a central line infection, now with persistent fevers and bacteremia after removal of the line, and we have an SVC thrombus, mobile friable mass extending into the brachiocephalic and subclavian. So we're concerned that this is an infected thrombus or fibrin sheath. He was started on anticoagulation at that time, and now we're planning on doing a thrombectomy. So we'll jump into the live case.
All right. Thanks, Dr. Carlone. Yeah, so it's an interesting case. The gentleman just came in sepsis with an infected perm cath. Everything was removed. Persistent cultures, despite everything looking good. So as part of that workup, he got an echo, looking for vegetation, some other reason for this. And then they saw this mobile mass. We got called about it and looked at the CT. And, for those of us that have been putting in dialysis catheters and are, used to these types of patients, we immediately identified it as a fibrin sheath. There may be some thrombus associated with it, but we're not going to split hairs about it. In essence, we're going to be taking out a fibrin sheath. Probably has some sort of biofilm on it from the catheter. It's kind of a well-known thing. What are your guys' thoughts? How would you guys set this up? Obviously, we're going to show you what we're doing in just a second. Is this a good idea? Should we not be doing this? What do you think?
Well, let's see how this thing works on a fibrin sheath, I guess. I don't have too much experience with this device. I was looking forward to the talk about it to learn a little bit more. But by looking at the pictures, certainly coming femoral is the right way to go. It gives you the best approach to come at the clot. So let's see what you can do.
I think.
Yeah. So I mean, it's definitely going to be. Go ahead. Sorry.
No, I think you guys are going to use AlphaVac, right?
Yeah, the plan is to use AlphaVac. I think Dr. Young was going to give a talk on that. Did we jump in before then?
Yeah, unfortunately.
Okay.
But it's okay.
You're about to hear a lot about it. Yeah. But yeah, so the plan is to use the AlphaVac. There's some advantage of it that you're going to see in just a second in that it has a big funnel at the end, which can provide some protection. This is almost definitely going to be very, very adherent. And so we have some options in terms of running a Fogarty to try to get it out. But yeah, we'll see what we can do.
There are two different types of AlphaVacs.
Show them the initial fluoro run. So right now we have right upper extremity access in order to do like this initial run. So what's interesting on the CT, he does not have symptoms of SVC syndrome, but here it looks like it's much more stenotic than it does on CT. You can see the filling defect up top. In the right atrium, obviously, you're not going to see it. That's why we have TE guidance. And yeah, we're just going to proceed. We have in the right groin, the AlphaVac. We have a 26 French dry seals are set up with the F22 AlphaVac setup. In the left groin, we usually have a prep here in case we need IVUS or any other adjunct. And then, like I said, in the right upper extremity, it's just a regular sheath for venograms, plus or minus if we're going to Fogarty. So right now, Aaron's going to show us deploying the AlphaVac, the funnel, under fluoro. Here,
so you guys can focus in on the hand here. So we have the handle here, which is very nice and ergonomic, and there's two settings here. This is 30 and 10. I think right now it's set up to do 10.
Yeah, so we would switch it over to 30.
I think we'll switch it to 30. So you could
no, this way.
Was it this way?
Yeah.
So you can adjust the amount of
if you're
your
not sure where you
suctioning.
are, you can do the yeah. So it'll give you a 10 cc pull. It basically stops the handle from coming all the way back. If you're unsure, you can do an initial 10 cc pull. And just as with any device, if you're getting some resistance, if you're pulling and the chamber isn't filling up, then you're probably up against something. Just make sure.
Dan, are you always
You guys can
using
see
TE guidance for these cases?
So for a case like this, we don't really have a fluoroscopic way of visualizing it. So first of all, even if you think you got it, you want to see what's remnant, but your options are really going to be IVUS versus TTE or TE, whatever you have available. We're lucky to have Rob here to help us out and guide us. But if not, we do these cases with IVUS, and we can just put a left groin sheath in there, put up the IVUS, and kind of guide us that way as well. Actually, do you want to show, so we can show in real time, Rob, do you want to show us, the images you had before?
Oh, that'd be
and if we
great.
could focus the camera over there. And Rob is going to find us a nice image.
These are intraprocedural?
Yeah, so everything you're seeing now is live. So there you can see the, yeah, we're going to film on there.
Oh, sure.
You'll see it hang, there you go. So this is in real time. What you're seeing there is the SVC cable atrial junction, and then in a second you're going to see the AlphaVac extending towards it. So we'll do this in real time, and there you can actually see, if you can show us the AlphaVac catheter. Yep, there it is. So that is the tip of the AlphaVac. So let's do a split screen. Let's get the camera. We're going to position it so that you can see the echo, and then you guys can see fluoro live as well. You have the split screen? All right, there you go. So you can see the AlphaVac. The two lines you're seeing is the edge of the cannula, and then inside of it, like a centimeter or two, you see those radiopaque marks. That's actually the funnel. So when Aaron is ready to go, he's actually going to loosen the blue connector, and he's actually going to unsheath the funnel. One of the nice functions of the device is that it has an angle. It comes in a 20-degree and then a 180 that we wouldn't actually use here. And depending on how much of the actual funnel you unsheath, right, you can get more of an angle, or you can extend it further on and actually kind of straighten out the cannula a little bit. And obviously with these images, the advantage of TE guidance is obvious here. Whereas if you look at the fluoroscopic image, you really wouldn't know the direction that you're angled into.
Yeah, I've used the
Okay.
AlphaVac once in these cases, and the TE makes a big difference.
Yeah.
So to get
Is that
that device up from a femoral axis, where do you like to extend the wire just to give yourself the stability to get a device that large up to the heart?
Sure. So as we were putting this in a case like this where you know you're going to be very, very adherent, you can just put the wire across it. We actually have a wire across from the neck. We're not really worried about knocking anything off or it going anywhere. But if you wanted to, we could really put it into the atrium and then just very, very carefully with like the dilator and the rest of the sequence. The device, similar to the Cat16 and other devices, is meant to be used without the wire. So when you're ready to go, you pull out the dilator and the wire. So we had a wire from the right groin extending into the right atrium.
All right. So are you guys ready to see the deployment here? We ready
Yeah.
to go?
Yeah.
Okay. All right. So we could either push it out or sort of just pin and pull it. And I'm looking at the TE image here and the fluoro at the same time. So I'm thinking we should just sort of pull it back and push it out so it sort of engages the clot. So there we go. So now it's lined up with the outer portion of the sheath. And now it funneled open.
Very nice.
And it looks like we're close to it, but not exactly on it. What do you think there, Dan?
I would go up a little higher.
A little higher?
So obviously advancing
There we go.
with it open, you want to be very, very cautious. What's nice about this device is that you have a 42 French funnel. So you really have a nice opening to catch it. And it has a 20-degree angle. So on the echo, Aaron can actually angle it any way he wants to.
Yeah. I think we're right up against it here, guys. What do you can see the funnel on the echo. You guys can see that.
Yeah, we can see it. It looks great. You're right up against it.
Yeah, we should probably
Awesome.
Maybe we could just do one here, and then maybe we'll go a little closer. We'll see if we get it.
We can definitely do a couple pulls.
All right. So we're going to grab the handle, and we're just going to pull.
Yep. I would pull a couple times. I think we got it.
Nice.
Yeah.
A little piece of it.
Again, something.
I don't know. Something came
Something
out.
went in.
I'm going to bring it back a little. I don't see it there on the
Not
echo.
there anymore on the
Guys see it?
SVC junction there, so I think you guys got it.
Do you guys see anything? I'll pull it back so you can see.
Yeah, I'll defer to Rob.
Yeah, or it's in the
Scroll
PA.
around. I don't.
That was two pulls.
It's somewhere. So now what you guys are doing is
Gone?
is manually extracting that, or it's on a suction. How does the actual
so
extraction
if you guys want to
work?
focus in on the device here.
Yeah, so Aaron can show you how
That
the
was
device.
230 cc pulls, so we basically took out 60 cc's, and it's just one each time, and so it fills up this little bag.
Can we
and the
see the video of you guys working? Yeah.
Yeah, there you go.
Do you guys have something back table set up for filtration? And when I do these, it's like
the way. Sure.
because
The
you can
way
give
that
the blood
this works
back,
is
right? But
sucking it
they
out to here and then pushing it into this canister.
It's probably somewhere in the tubing, if I had to
Yeah.
guess. So we're gonna have to take the tubing off and check.
Yeah.
When I disconnect his handle, is there something we should put over here for hemostasis?
I mean, this should be hemostatic, right? Because
Okay.
without pulling it.
All right, so let's disconnect it.
Yeah.
Are you anticoagulating the patient?
Yes.
Yes.
The patient is heparinized. The patient came down, was on a heparin drip, but we've also been checking ACTs.
Go for it.
No, right here. We got a giant bowl.
Go for it.
All right.
So you
And-
don't see any evidence that it's there anymore on the echo. I don't either.
No, it looks great. I mean, Rob, I'll let you look around. I don't see anything else. Is there?
It's pretty nice to be able to see a funnel under TEE. It gives
anything?
you a really good visualization.
Yep. So yeah, we definitely got it. Oh, there's the hammer. So this is the fibrin sheath. I mean, it's very, very chronic. Here, I'll hold it up for you. And we have some in the bag as well. But obviously, you can't feel it. It doesn't really have like a white pinkish, but it's very, very rubbery. The things we're used to
Sure.
with like very chronic appearing things.
Mm-hmm. So can you walk through how you use that handle and what exactly is happening when that clot's coming out?
Yeah, absolutely. Can we focus the camera on the handle again? So basically,
You go.
the pull, we have the, oh, you okay? Um, so the way that the handle works is it's pulling suction, and you can see that this is connected to the patient, and then it's pulling in here, and then it pushes it back, and it's basically a series of like one-way valves that are pushing it into the bag, into the tubing. And so every one of these pulls can give you 30 or 10. The handle pulls that way. It's similar if you had like some devices have a 60 cc syringe that you pull negative pressure and then turn a sheath.
Right.
There's other devices that kind of work similarly, but you're basically doing 30 cc at a time. It's a smaller pull. The advantage is, for example, if you're lollipopped or if something is corked, you can do multiple pulls and sort of build up the pressure. So that's kind of one of the advantages of having it in this type of a setup versus, for example,
No,
having
just
like a big
culture.
syringe, which you would have to empty onto the back table and come back. So you can kind of build up pressure exponentially.
You can see there's a film on it.
At the same time, it's a
See that?
smaller pull, so it's less power, but at the same time, you can do it repeatedly. So it's kind of advantages of disadvantages of different devices. I think the big advantage here is had something gotten corked, we could kind of do repeated pulls here, and then we have that 42 French, the 14 millimeter, really basket around the catheter that would kind of give us some degree of embolic protection as well. So all those were kind of thoughts in terms of device selection. I don't think there would have been a wrong device in terms of kind of what we're usually using, since this is what we're doing in this session. What do you guys think? Would you guys have tried something else? Is there a different setup you think would have worked above?
I think it looks great, man. This is a great result. My question to you
Yeah.
is, the literature and what you did is kind of consistent with this clot in transit with angiovac, and it seems like it works well, and this is a great application of it. The one time I used it was a more complete obstruction of the SVC, and I wonder, do you have any experience with that, with using the AlphaVac without flow there? Are you able to get like good penetration to the clot? You're able to suck out more chronic clot, things like that? Because that would change my tools I think I would use in this setting.
Yeah, no, it's a great question because, I mean, at least in my experience with the larger bore thrombectomy devices, sometimes you want to give yourself a little bit of distance to kind of build up some momentum. If you're right in it, kind of corked, you actually won't get good flow. I haven't done AlphaVac in a completely occluded segment like this, so I couldn't answer that question. But I don't know. I mean, it really got a good pull on what was chronic. I think it's definitely worth a shot. There was a conversation whether to use AngioVac. But I've been told that this actually has a greater suction power than the AngioVac, so I think it's definitely worth a shot.
Any
The
thought?
ergonomics of this device is very good. As you can see, it's just a much, when you're doing syringe pulls, as an example, with something like a Nari, it's nice to have some sort of manual component to it where you feel like you're actually doing it. With a penumbra system, as an example, you don't necessarily get that. I've used this in a PE case, and I've had great results. I mean, we've gotten out all the standard PE stuff, acute PE, with this, and so the suction power is quite impressive. I mean, you can sort of feel it sort of vibrating in your hand as it comes through the tubing.
Aaron, one of the things about it that seemed like interesting for PE work was that you can kind of torque that funnel in the right PA or the left PA instead of kind of jumping the Inari to different segments. Do you find that you're able to do that and kind of suck out more from just a more proximal area with this?
Yeah, I like since the funnel opens up to a larger diameter. I like putting it as proximal as possible, and then tracking it out later. So when we're selecting cases to use this on for a PE, for example, we probably would use this on a more proximal PE to start. Something like a big saddle where you can just put it right up into the PA and open up the basket and just bring it down.
In a
Much
case
easier and faster than other stuff.
in a case like PE where you don't necessarily have a modality like TE to help identify the clot, do you get a tactile sense with this when you've latched on to something?
I don't think so.
I mean, it's not as strong as some of the other devices, but with the handle, sometimes you can get a little bit. What you don't get necessarily is kind of the vibration response that we're used to with an
I
Inari.
mean, if you get a big enough thrombus in there, I can feel it, but it's not the same that you're going to get when you feel like that vibration of the tubing with some of the other devices. But being able to use a handle, I think, is really, really nice.
Yeah, I mean, if you're in a more confined space like a pulmonary artery, I think the directionality may not be as vital, but I've done the other cases that I've done have been like catheter associated. Again, something hanging out in the right atrium. It's a big space, small target, and being able to control the directionality in real time by basically uncovering the funnel because it has a 20-degree, and then being able to straighten it at the same time, it provided the directionality was very useful in big spaces like this one.
So you have on the device, you have the 10 and the 30, and you have the lock and unlock.
Yep.
We can take the device out if you want, and we can just show the flexibility
let's
of
do
it
that.
as well.
There are two different sizes of the catheters, right? This is the F22 that you guys are using.
Yeah, so this is the
25.
F22.
It's 25 French, right?
The outer is 26.
And we're using a dry seal.
It's a 26 dry
You
seal.
guys can see the dry seal here.
The F18 is, I mean, Lindsay's about to actually give a whole talk on this, but basically the F18 is what's going to be used in Apex for the PE space. So this is a 26 dry seal, a 22 catheter there.
Here's the funnel here.
Can you torque
So
it from the
when you
handle?
deliver it. Yeah. We can torque it. Let me see. Here, you want to torque it while I hold it?
Sure. Here, we can take this off.
Sorry. That's a good picture.
So if we turn it around,
See, he's moving it there.
so I don't know. Yeah, you guys can see that.
So it's a subtle movement, and the
Yeah.
more of the catheter that's sticking out,
Yeah, the
it'll
more
torque
of a
more.
bend
But you can
get.
see that there's a slight bend here.
Yeah.
The
That gives you
radiodense
the ability to sort of manipulate.
markers we were seeing on fluoro, what do those correspond to? It's the end of the basket and then the end of the outer
It's
sheath or
these
inner
two
sheath?
right here. They were both. So when you initially saw it, it was in this configuration, and then he basically expanded it out. Yeah, there you go.
So the top,
So-
the top markers are from the basket. The
Yeah.
bottom markers are from that delivery sheath.
Yeah.
And then before we had it out, you guys can see it was lined up. I don't know if I have an image of that.
So yeah,
But-
if you can zoom in a little bit more on the catheter tip, yeah, and so that kind of matches up with what you're seeing
Yeah.
on the fluoro screen.
How long is your dry seal?
It's about in the intrahepatic cava. It's about like 30, 40.
It's hubbed, and you guys can see the tip down here.
Got it.
You guys want to do a run to show how much it
No,
opened?
it's a little
Oh,
short.
there it is. It's pretty
All
small.
right.
It's pretty low.
I think we actually have to go over to the filter retrieval. They're ready to go. So happy to answer any of the questions, if they come up later on. But I think we're gonna head over to room 1. Thanks, guys.
Thanks.
Thanks,
Awesome.
nice
job.
result.
Awesome
5 minutes,
case.
I'm told.